Welcome to the Palliative Care Networking meeting. My name is Adrienne, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we'll conduct a question-and-answer session. I'll now turn the call over to Janelle Scheer. Janelle, you may begin.
Hi, everybody. I would like to welcome you today on behalf of Stratus Health, the Minnesota organization that is part of the Lake Superior Quality Innovation Network, or LSQIN. The LSQIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome you to the Rural Palliative Care Networking Group. This is a group that meets virtually 3 times a year to network and learn. It's for those interested in providing palliative care services, especially to those in the rural areas. People from all disciplines and settings are welcome to participate. Our educational session today is the role of the POLST in advanced care planning. This is a webinar number 2 of a 3-part series on advanced care planning, which has been going on in 2017. I'm pleased to have Karen Peterson, the Executive Director of Honoring Choices Minnesota, here with me today as our presenter again for this webinar. Before I introduce Karen, I'll just remind you that all the lines are muted during the webinar. However, after the presentation, we will have a time for questions and answers, so please take note of the questions that may come up as you listen. We're also utilizing the chat feature, which you will see on the right side of your screen there. And we have put in a question that we just would like people to answer, where we have you identify the type of your organization that you work at, and if your organization is currently using the POLST or not. So if you would do that, that'd be great. That way we can see what type of organizations are on the call today. Okay, now I would like to introduce Karen. Karen is the Executive Director of Honoring Choices Minnesota, a public health initiative of the Twin Cities Medical Society, which focuses on bringing advanced care planning to all parts of our state and beyond. Karen received her BSN from the University of Minnesota School of Nursing, is a frequent speaker on this topic, and enjoys presenting to diverse groups about the importance of understanding advanced care planning so that every person can share their goals and values about end-of-life experiences. So thank you, Karen, for coming today and presenting on the POLST.
Thank you very much, Janelle. Today, as the title indicates, we'll be talking about the POLST form, which isn't traditionally part of advanced care planning, yet it's connected because it's on the continuum of end-of-life care. So our objectives for today are to understand the difference between a healthcare directive and a POLST form. We're going to go over the 5 sections of the newly revised POLST form and talk about the intent of each one of them. And then throughout my talk today, I'm going to be bringing up some common issues and challenges that we have seen throughout the state over recent years, and talk about ways that future challenges can be avoided. So thanks for being here, and here we go. And like Janelle said, we do have the chat open, and so I will try to follow if anybody makes comments or questions that are typed in. I'll respond to some of those ongoing. Otherwise, we'll take questions at the end. So, POLST is actually a national movement that is seeking to provide better end-of-life cares throughout our entire nation. And in Minnesota, the POLST efforts have been housed with the Minnesota Medical Association. The leadership there has convened a group of healthcare professionals from around the state who work with end-of-life care, and that's the team that monitors and develops the forms and the policies and the guidelines that are used in our state. Honoring Choices, the organization that I represent, is a public health initiative focused on advanced care planning, and we do frequently get questions and requests for advice about use of POLST because it is, as I said earlier, kind of on the continuum of advanced care planning as patients and individuals move closer to the end of life. So before we get into the new form, I wanted to just go over the POLST in general to make sure that we're all on the same page. and that we're all starting at the same place for this seminar. So, just a real quick, what is it? Well, POLST stands for Provider Orders for Life-Sustaining Treatment. It's a medical order signed by a provider, and it is specific directions on medical treatments to be used. It takes some of the information from a healthcare directive and translates it into medical orders. Who needs one? Officially, the POLST target population is meant to be people who you would expect to die or not be surprised if they were to die in the next 6 to 24 months. We know, however, that often POLST is used more broadly, especially in long-term care facilities, so we're going to talk a little bit about that later on. And then remember, I just want you to keep in mind that the default for someone who does not have a POLST is to have full code status and patients will receive the most aggressive treatments. So we say when we're talking about advanced care planning is, and the reality is we all have one, it's just a question of who wrote it. And that takes us to our next point. Who does write this? Well, in Minnesota, the P in POLST stands for provider. In a lot of other states, the P stands for physician. And you will occasionally see in Minnesota that the P is referenced as standing for physician. And I've had many discussions, sometimes even arguments with people over whether the P stands for provider or physician. But officially in Minnesota, it is provider. And that was very deliberate in our state. We wanted to broaden the ability to write this form to more than just medical doctors. So provider in Minnesota means a medical doctor, a nurse practitioner, a physician's assistant, or a doctor of osteopathy. Now in some other states, they avoid that question altogether by having POLST with an M as their acronym, where the M stands for medical orders for life-sustaining treatment. Finally, sometimes I'll get the question of, is a POLST legal? Well, usually what I've learned is that when the question of legality comes up, the concern is actually, will this piece of paper be followed? By whom and under what circumstances? Well, a medical order will be respected by medical personnel. So it will be respected by healthcare providers, including emergency technicians, as long as they're aware of its existence. And we'll talk about how to make them aware in a little bit. Now, a healthcare directive becomes a legal document through signing and witnessing, and then it becomes a valid piece of evidence which could be used in a legal court of law. A medical order, on the other hand, becomes valid through the signature of a licensed provider, and then that order is followed. Now, I want to share a couple of examples recently that have come up that show that there can still be problems even when a POLST is written or is used. And this is part of the reason why we're doing this seminar. There was a recent example in the Twin Cities where a woman was transferred from a hospital to a transitional care unit, and soon after the transfer she was found arresting in her room, and the EMTs were called because she did not have a POLST in her transfer orders. The family was also called. The EMTs arrived, started CPR, and then the family arrived and said, no, stop. She does not want CPR. She is DNR. And there was some confusion because the family insisted that there was paperwork to support this, but the paperwork was not available at the time. Now, if the letter of the law had been followed, the EMTs should have continued the CPR because they lacked a medical order telling them to stop. However, in this situation, the family did convince them to stop. The CPR efforts were halted. Ultimately, the patient did die later, and ultimately, paperwork was produced to show that the family was in fact correct, that the patient was meant to be DNR. The outcome in that situation was that the EMTs were placed on paid leave throughout an investigation, but ultimately, because it could be proven that the patient's and family wishes were being followed accurately, there was no punishment taken against them. So that's an example of where the POLST did get written, but it was just not accessible. Nobody knew where it was. The admitting facility did not have a copy to be used in this situation. Now, a second situation happened a couple of years ago, also in the Twin Cities. It was an elderly patient who was a long-term care resident. She had a POLST saying that she wanted full code treatment. She wanted CPR attempted if she were to arrest. Now, in the time since the POLST had been written, her Alzheimer's had progressed and other physical situations had changed, and her health was declining. And discussions had begun with the family, with the healthcare team, and with the providing physician about changing her code status. And it was clear that there was an intent to change her POLST to say DNR, but the actual paperwork hadn't been filled out yet. And the patient was found unresponsive. Protocol normally would have said that CPR should be administered because her current POLST said she wanted that, but the staff declined to call the code because of the discussions that were happening. So in this situation, the POLST was available, but it wasn't followed because there was a knowledge of an intent to change it. But since it had not been changed, this facility was cited by the state for neglect, and they did receive a penalty for this patient care decision. So those are two examples of what can happen when POLST is not used or filed correctly. So I mentioned earlier that POLST is a national movement. This is a map from POLST.org, the national website, and you see that all of the states are different colors of pink. The darker your color is, the more advanced your POLST program is. So you can see that Minnesota is pale pink, which is one step above white, which is good. That means that we are developing our program, and our goal is to get our state to be a darker pink. And so part of what we're doing with this new form is meeting the guidelines offered by the National POLST Paradigm to achieve the endorsed status, which will make us turn darker pink. On the National POLST website, there are a bunch of guidelines for developing programs. I have paraphrased 5 key guidelines to highlight today, but I encourage you, if you're interested, to go to POLST.org and read the resources and information that's available there if you'd like to learn more. So the first guideline that I want to emphasize is it's about the conversation. Now, those of you who have heard me talk about advanced care planning have heard those words come out of my mouth, but I'm talking about advanced care planning at any stage of life. It's always about the conversation. POLST is no different because it's still critical that the patient, whenever possible, and loved ones, if applicable, are included in this decision. POLST needs to be person-centered, and it needs to be shared decision-making. If you look at it from the other side, if you were to complete a POLST without any involvement from the patient and the family, it really is against the intent of this form. It violates the principles of informed consent. If you think about other situations where informed consent is called for, imagine it being brushed aside or completed without patient involvement based on the assumptions of the caregiver. That would never fly. And it really should not be acceptable for POLST either. POLST should not happen without involvement. Now, the reality is that for a medical order, a conversation with the patient and the loved ones is not technically a requirement. But if it's not part of the process, it really needs to be documented why the patient and the family members or the loved ones were not involved. Sometimes it's as simple as the patient is incapacitated and no family members are reachable. But it should be indicated that an attempt was made, and if it was not successful, why not? Number 3 is one that's near and dear to my own heart because of a personal story. My mother has multiple health issues, including Alzheimer's, and upon my urging, or she might say insistence, changed primary care providers last year. She changed from an internal medicine physician to a geriatrician. And after her first appointment, which my dad took her to, I was quite surprised when I got a phone call that at the end of the appointment, their new geriatrician gave my father a stack of paperwork and told him to read it over and that there were some forms in there that he should fill out and bring back to her next appointment. And so he was calling me because he said there's this yellow piece of paper that says POLST on the top. And what is that? Now, you wouldn't do that for any other type of medical treatment. Send a blank form home with a patient and their family member and say, oh, you just fill this out and bring it back and then I'll sign it. The POLST form is written to be very easily understood by patients and loved ones and non-medical people. But it should never be given out without a professional there to go through it, explain it, and interpret it, and answer questions. It should never be given to a family to take home and bring back filled out. I can't think of any exceptions. I very rarely say never, but this is one I think never is appropriate. Number 4 is a little bit tricky. It's a guideline from the national paradigm, but I know that in Minnesota, and I assume in other states as well, many facilities use Section A to meet requirements that every patient or resident has a documented code status. And that's actually fine. You know, the POLST form is very clear, it's very easy, it can be very quick to use Section A, and you don't have to fill out the entire POLST form. You can just fill out Section A and sign it and have it be an order, and that's totally fine. However, I strongly encourage you to have a process in place wherever you work to ensure that even if you're only doing Section A, you still have a conversation. You don't base it purely on transfer orders or previous admissions. There really needs to be a confirmation conversation as soon as possible. And then also, I strongly encourage you to have a protocol in place to come back to Section B and potentially Section E on page 2, so that you do have a conversation about the entire POLST form, not just leave it with Section A. If your site currently is just using Section A, I'm not saying that's not okay. I understand that for a lot of situations, that's what resources are available, and that's a great starting point. But I would strongly encourage you to try to figure out a way to go farther than just using Section A. And finally, the 5th guideline is that this is not a one-and-done document. And that's, again, the same thing we say with the healthcare directive. Things change. Health changes. Diagnoses change. Goals and values change. And so the POLST form should be reviewed regularly. Many sites have a protocol about reviewing a POLST. Some states or some facilities require an annual review and a signature from the provider. On some states, on the POLST form itself, there is a place for multiple signatures so that it can be reviewed and re-signed annually. We just didn't have space for that on the Minnesota form. It was discussed, but ultimately decided that that needed to be a separate form that was created by separate institutions based on their own protocols. Another situation where an annual review is required is if the patient is incapacitated and has a state-appointed guardian. Then a healthcare directive and the POLST does need to be reviewed annually. And some sites or systems may require a review and a new signature with every transfer or admission. So you need to find out what your site and your workplace requires. And if the policy seems well written and well followed, you are doing great. And if there is no policy, or if the policy after today you're thinking could use some updating, I would encourage you to start that process so that we can be sure that the POLST is being used properly. Next, I'd like to cover a little bit of what's the difference between a POLST and a healthcare directive. I mentioned earlier that they're on different places on a single continuum. And oftentimes I'll hear the question, do I really need to have both documents? So the first difference I want to point out, and this is really the difference that makes the most importance for healthcare professionals, is that a POLST is a medical order, as opposed to a statement of patient preferences, which is what a healthcare directive is. Now, related to that is the piece of information that often is the most important to patients and their families, is that a POLST will be followed by EMTs. I hear a lot of questions from people who have a directive but not a POLST, who say, I took all this time to write this directive, and what do you mean the EMTs won't follow it? And then I have to explain the difference. A POLST will be followed by EMTs, as long as the EMTs know that it exists and they've been trained to read it. EMT training is critical, and we actually would encourage you to talk with your local emergency providers to make sure they really are clear on how to follow a POLST and that they understand the differences in the new form when your institution starts using them. This webinar will be available in a couple of weeks, and we would urge you to share the link with anyone in your system or in your community who you think would benefit from receiving a little bit more information on how to best use the POLST. Another big difference is that the POLST does not include a designation of an agent. Now, there is a spot on the POLST to write in the name of the agent if one has been chosen, but the POLST does not include or require a designation of an agent. Now, if there is no healthcare directive that's named an agent, and the patient does not have the ability or the capacity to name their agent, who makes decisions for them? In Minnesota, our law set by the state is that we do not have a legally designated hierarchy for decision-making of this type of healthcare situation. We're actually just one of 12 states that does not have that. Now, many systems cover that by having a system protocol in place that often will follow a hierarchy of spouse, adult children, spouse, parents, adult children, siblings, and then other relatives. That's very commonly used, but you might want to find out if your system has a protocol. And then, like I said, you need to be aware that Minnesota state law does not indicate who can make these decisions. What the state law offers is that the primary healthcare provider has the authority and the responsibility to choose who is acting in the best interest of the patient. Now, a problem occasionally will occur where there's no one to choose from. You may have a patient who is incapacitated, a resident, and there simply is nobody to talk to. Providers tend to be risk-averse, and so they are going to want protection for the decisions that they make as far as treatment. Unfortunately, what this sometimes translates into is an ethical issue, because if a situation is deemed as a life-threatening emergency, consent is considered implied and the provider has a right to treat without any threat of penalty, which means that sometimes patients are allowed to decline until an emergency status before any treatment can be made. There aren't any solutions that I can offer you for this other than to talk about the importance of prevention. The saying, an ounce of prevention is worth a pound of cure. If we can all be more aware of the need for earlier advanced care planning and earlier designation of substitute decision makers, hopefully we can minimize the number of people who that type of situation occurs. Finally, a POLST does not include any helpful information about the patient's goals, values, past experiences, or desires, all of which can and should be included in a healthcare directive So therefore, we strongly recommend that if you have the ability to work with your patients, that they do both, that they complete a healthcare directive where they can include this other information and they have a POLST if their health situation warrants it. Now, we know that time is a huge barrier. And so we just want to remind you that there are the 2 new CPT codes that have been around for almost a year and a half now that do make these types of conversations reimbursable. Now, there are some conditions that have to be met, but it is possible. And if you are unaware of those codes and would like more information, you can email me and I can send you some resources about how to use those codes so that you can get some reimbursement for these types of conversations. And then the other solution I have to offer is if you are in a community that has advanced care planning community volunteers, or if you'd like to start a program with volunteers, that can be a way to get around the time constraints by having non-employees specially trained to have these types of conversations with your patients or your residents. And that's working very well in a number of communities throughout the state. So if either of those are something that you'd like more information about, please feel free to contact me after this seminar. Okay, that was kind of a long introduction. Now let's jump into talking about the new form. The form is now available for downloading at polstmn.org. So if you don't have a copy of it in front of you right now, and you have a printer handy, you could quick print yourself one. Otherwise, I have it up on the screen as we talk about it. So, like I said before, the Minnesota Medical Association leads POLST in Minnesota, and the team that I described earlier, kind of the POLST committee or POLST task force, has spent the better part of a year updating this form, and I'm part of that team. We took into account a lot of POLST forms from other states and looking at our current POLST form and feedback that we've gotten, and this is what we came up with. Now, I do want to say the old form is still valid. There's nothing about the new form that invalidates the old form, and so if you have a stack of the old ones and you want to keep using them, that's totally fine. Each system and site can determine when and how they want to switch over to the new form. So, we're going to start by looking at side 1. One of the first things you may notice is up in the top left-hand corner, it actually says Minnesota. As crazy as it may seem, our old form did not say Minnesota anywhere except the footer on the back. So, it was recommended to us that we indicate what state we're in. Secondly, the line up by the patient's name. On the old form, there was some confusion. People weren't sure whose name they were supposed to write in there. It said, the old form said primary care provider, and what was usually getting written there was the current primary care provider in the new facility or in, if the patient was in hospice. And when in reality, the intent of that line is who has been the primary medical care provider? Who is the family physician? Who is the person who's been involved in this patient's care maybe for years? Because that's the person that we just want to, out of professional courtesy, let them know that the status has changed and this patient now has a POLST. If you look down to section D, that's the signature spot. Now, on the old form, the signature spot was really, really hard to find. It was a very thin line at the very bottom of the page that really looked like just a note in the footer. And so a lot of providers missed that and sign on the back. So we made it bigger. We made it an official section, giving it a letter. It's very, very clear now where this is to be signed. And I'm sure you all know that for an order to be valid, the signature has to be on the same page as the order is written. And so for all of the forms where the providers were mistakenly signing on the back, technically those orders weren't valid because the signature was not on the same page as the order. And speaking of the footer, we added the URL where the form can be found and where resources can be found because we are now such a computer-based society. And then we also added page 1 of 2 because sometimes when a double-sided form gets copied, it doesn't get copied as a double-sided form. And so we wanted it very clear that this is a two-page document. Now we'll go through the 4 sections one by one. Starting, as is logical, with Section A. Now, on the old form, the 2 options for attempt resuscitation or do not attempt resuscitation were next to each other, left to right. We thought it was a little bit more clear to put them one under the other. So it was very clear that they were 2 options, not 2 versions of the same option. And you notice it goes from most treatment down to least treatment. We also added a line indicating that if you choose attempt resuscitation in Section A, you must choose full treatment in Section B. Frequently, we were hearing of POLST where Section A would say, we want resuscitation attempted, and Section B would say comfort care. And those 2 are at odds. So we added this line to indicate that you really need to be consistent. Section B, keep what I just said in mind as we talk about the options in B. This is a very important change. On the old form, the options in Section B went from least care, or least aggressive care, rather, comfort care was listed first, down to the most. Well, we have changed that so that the order of options in Section B is consistent with the order of options in Section A. So if you choose the top option on A, you need to choose the top option on B. If you choose the second option on A, you can choose the second or third option in B. But we wanted to make them consistent and not going in opposite order. And then we also changed the language a little bit. I talked about how this form is really written to be user-friendly so that patients and family members can look it over and understand it, even though we do want the professional there to fill it out. But we added the treatment plan statement on each of those 3 options so that people could really understand what the options meant. Because one of the things that we hear about frequently is people would say, well, of course I want you to try CPR, and then it would be explained to them that that would necessitate transfer back to the hospital and the intensive care unit, and their eyes would get big and they'd say, no, I don't want that, because they didn't understand that that was part of CPR. So we wanted to make it a little bit more clear. Now, Section C is probably the biggest change. Now, you may recall on the old form that Section C was about additional treatment options, antibiotics, artificial hydration, nutrition, and then a blank space for other orders to be written in. Now, that section has been moved to the back, and I'll explain why when we get there. The new Section C emphasizes the importance of the conversation. It really is about the conversation. We want to have right there on the front an indication of who was involved in this discussion. Was the patient able to be involved? Who else was there? Was there a healthcare directive consulted? And then, in an ideal situation, we want somebody to sign that they were involved in this. If the patient is able to sign it, that's the best. But if the patient is not able to sign it, somebody else in their circle of caregivers and circle of love who is testifying that, yep, I was here, we talked about this, this order is consistent with what the patient wants. Now, again, the signature is not a requirement, but it is strongly recommended. And then one last point before we go on to page 2. At the top and the bottom, you'll notice a highlighted bar. These bars indicate that this form is compliant with HIPAA regulations, so you don't have to worry about that. This form can be duplicated electronically or by photocopy, and that is valid. And that actually brings up a point about the color of the form. We often get asked if yellow is a requirement. We recommend that the form be yellow simply to make it easy to find and easy to identify, easily recognizable as a POLST form. If you think back for a minute to that state map that I showed you at the beginning from the national POLST paradigm, it was all in pink. And that's because Oregon, when they started the POLST program, they chose to make their form bright pink, neon pink, which they still do to this day, and a number of other states do as well. Personally, a form with black ink on neon pink paper, to my eyes, is really hard to read. And I don't know if that's why Minnesota chose yellow, because that happened before I was involved, but I really prefer the yellow. I think it's much easier to read. However, it doesn't have to be yellow. It can be white. A photocopy that's on white paper is still a valid POLST form. Yellow is just to make it easy to find. And then finally, the third thing that those highlighted bars do is it indicates that POLST forms are meant to travel with the patient. If the patient gets transferred or is discharged home, they should take their POLST with them. So now let's look at the second page. The second page, first thing, this is kind of like adding Minnesota on the front. Somebody said, you know, we really ought to have the patient name on page 2. Kind of embarrassing that we didn't notice that before, because like I said, oftentimes when this form gets copied, it does not get copied as a double-sided document. It ends up being 2 pieces of paper, and the second page had absolutely no indication of what first page it went with. So we added that blank on the top. Then we moved to section E. And you remember I just said this used to be section C on the front. It was a space for additional medical orders. Well, the reason we moved it to the back is because these things in and of themselves are not actually medical orders. They are indicators. They offer an opportunity for a preference to be stated that a patient may or may not want or may be open to additional treatments. But any of the boxes on in this section that are checked are still going to require the provider to write actual additional orders. You know, if you look at the nutrition section, the first checkbox is long-term artificial nutrition by tube. Well, that doesn't indicate what kind of tube or where that tube enters the body or what type of artificial nutrition is going to be provided and what the dosage is going to be, how much, how frequently. So any of the boxes that are checked there indicate a patient's interest in those orders or those treatments, but additional orders are still going to be needed to be written. So that's why it was moved to the back. The 2 sections that have checkboxes are nutrition and antibiotics, but then this blank lines where it says additional patient preferences, this is a fabulous place to talk about trial intubations. Because you may have noticed that on the front in section A, intubation is not part of the CPR discussion with this form, because there can be many other situations besides a code or an arrest where intubation may be medically helpful. And so this would be a good place to indicate whether or not the patient has talked about, thought about, and is open to the idea of intubation, and if they want to put any time parameters around it. Continuing down the back side, or page 2, right in the middle, we want to know who the healthcare provider is that's working with the patient and the family and talking through all of these decisions. Now, in some cases, it's going to be the same person as is the provider signing on page 1, but we know in many cases it's not. In many cases, it may be a nurse or a social worker, or a chaplain or an administrator who is holding these conversations, but they are not licensed to sign the document. But we still want to know who it is. In fact, I've heard from some physicians that if this section is not filled out, they won't sign it until they know who helps the family, because they want to know how much discussion there was, and they want to understand how much information was shared by someone who is qualified to do that. One of the things that we've already got questions on this section is you'll notice, and then it's kind of hard to see on your screen, maybe it's easier on your computers right in front of you, but I'm looking at a screen across the room. Next to each blank or each field in this section is the word required, and it's written in bold. We've already gotten inquiries from what happens if this section is not completed. What if the provider who signed it is the one who went through the conversation and doesn't feel a need to enter their information twice? Because the fields say that they are required, some health information management teams or medical records people may reject this form because they'll say, that's required information. We have to have that for this to be valid. I've heard it both ways from two different systems in the Twin Cities. I think this is just something that you need to be aware of and check with your policy-making team about whether or not this is going to be an issue. And if it is going to be an issue, then you just need to make sure that everybody is aware that this section must be filled out. One person I talked to suggested simply writing in same as front, and their health information teams told them that that would be sufficient. So you need to check to make sure that there aren't going to be any red flags within your system so that the forms are filled out so that they will be received and acceptable and put into the medical records. The bottom part of the back page is information, first a note to the patient, and then directions for the healthcare providers who are completing the POLST. And this was rewritten, again, to be a little bit more user-friendly, to make things as clear as possible, and to make things easy to understand, to hopefully avoid or ward off questions from either the patient or the healthcare professionals working on this. Finally, down in the footer, it does say page 2 of 2, just like the front page says page 1 of 1, and the revision date is added so that you know when the form you're using was created. Now, like I said before, this new form does not invalidate the old one. You might want to talk with people at your system about how you're going to move to the new form. It could just be an organic change over time that people start using the new one, and eventually all of your patients who have a POLST will be under the new one. Or you may choose to do it a little bit more deliberately. I know that Lakewood out in Staples, Minnesota, is going to choose a date, and they are going to change every single one of their patients with POLST on that date. So they're going to make a complete systemic switchover on a specific date, and they're gearing up for it, and they're going to make it an event. Either way is fine. You know, it's whatever is going to work for you. Depending on how many people you have who have POLST, it may be a simple or it may be more of a long-term changeover. And then as far as the form itself, we don't anticipate changing it anytime soon again, but as you start using it, and as you start becoming familiar with it, if you have suggestions or feedback, please do let me know. I'll take it to the team. We take everything we hear into consideration for future updates. And quite frankly, if we hear from 25 people over 3 days that there's one glaring error, we'll make that change sooner rather than later. We certainly are not hoping that that's the case, though, because we did have a lot of people go over this form before it was finalized. So finally, just to give some final comments, and then I'll take questions. POLST really is a valuable tool. It can translate patients' goals, values, and wishes into medical orders. It can provide clear and easy-to-follow instructions for healthcare professionals. It's best done using the entire form, all of the sections, based on conversations with the patient and loved ones. It allows caregivers, through those conversations, to really get to know their patients and understand their goals. And when policies and procedures are set up well, and staff is trained, POLST clearly can diminish confusion and decrease chance of medical error in a crisis situation. You can please feel free to contact me at any time if you have questions or if you would like more help or more resources. If I don't know the answer, I will help you find the right person or direct you to the appropriate resources. And then the one final thing I want to say before we open it to questions is you will be getting a survey as a participant in this webinar. And it'll ask you some general questions about this webinar, and then at some point in the survey, there is a comment section where you can write in whatever you want. And I have a personal favor to ask of you. In that comment section, I'd really like detailed feedback on how helpful this seminar was, because I'm hoping that this will be something we'll repeat in other venues. I want to know, was the balance right of what is POLST versus what are the changes on the new form? Do you think this will be something that you will share with colleagues and or with emergency workers in your area? And if there's anything else that you noticed or thought about during today's presentation that you think would have been helpful, or something that was included that you think was unnecessary. I really, really would appreciate your detailed comments back so that we can make this training as effective as possible. Thank you all very much.
Thanks, Karen. Lots of great information and many good changes to the new form. Adrian, we'll have you open up the lines now for Q&A from the participants.
Thank you. We'll now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There'll be a delay before the first question is announced. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have an audio question, please press star, then 1 on your touch-tone phone.
While we're waiting for the first audio question, there are already questions coming up in the chat file. And somebody said, Danita says, if a person has a directive and or a POLST, can the family override it? Technically, letter of the law is no, they cannot. The agent potentially can, but the family in general cannot. Now, the reality is, I'll be honest with you, is that it does happen. Usually if this happens, what will occur is that an attempt will be made to stabilize the patient, and then a family care conference, potentially with ethics people, will be called to try to come back to a sense of agreement about what would be in the patient's best interest. But technically, legally, the agent is the only person with the power to change anything. And the agent shouldn't be doing that, because if the agent is well trained and has had the conversations with the patient to truly understand the patient's goals, values, and wishes, an emergency situation would not be the time to make a change. And then another question from Polly asks, can a provider sign a POLST without a signature from the patient or family? Absolutely. A provider can write a medical order without a signature from anyone involved. We strongly encourage a signature to be obtained if possible to indicate, because this is really, literally, this is a question of life and death. And so having a signature from the patient or a close family member or the agent indicates that they were involved and that they are saying, yes, we agree that a discussion has happened and this POLST form is in alignment with the patient's wishes. But technically, no, a provider does not need a family or patient signature to write a medical order. A question about the billing component. Is this reimbursable from an outpatient setting only? Would it apply to inpatients? There are requirements about settings. As far as I know, and this is something, I don't have the paperwork in front of me, but I can find it. Laura, I can email it to you if this isn't enough. Or maybe somebody on the call may know the answer too. But as far as I know, pretty much any inpatient setting is covered. The question comes from who is actually doing the conversation. If a provider is doing the conversation, you're set. If someone who is not the provider is doing the conversation, in other words, if it's a nurse or a social worker or another staff member, it does have to be a staff member to be reimbursable. It can't be a volunteer to be reimbursable. Then it needs to follow the incident to protocols, and that's the piece piece that I can't quote off the top of my head, but I can send you information that clearly outlines exactly who and when and how these qualify for reimbursement.
Adrienne, are there any questions in the queue?
As a reminder, if you have an audio question, please press star, then 1 on your touch-tone phone. Standing by for questions in the queue.
Okay, well, I have a couple of questions, Karen, while we're waiting.
Okay.
Can the POLST be used across state lines? So, for example, say there's a Minnesota person living in northwest part of our state, but they do their health care in North Dakota. So they're in a hospital in North Dakota or a nursing home. Is the Minnesota POLST valid, or do they need another one?
Janelle had to ask me a question I don't know the answer to. My first impulse is to say it would depend on whether or not the signer is licensed in both states. Because if a practitioner, a physician or an advanced practice RN is licensed in both the states you use, North Dakota and Minnesota, then there would be no problem as far as I know. If that's not the case, I'm honestly not sure. I would say, well, I know, I'm hoping, Nancy Joyner, I'm going to put you on the spot. I think you're on this call. For those of you who don't know Nancy, before I even asked, she already quoted, most states accept reciprocity across state lines. Clarification is made within protocol and policy. So I know that in Minnesota, when it comes to healthcare directives, we do accept directives from other states. So I'm assuming that we would also accept POLST. So if you work in a border community where you have patients who live on both sides of a border, you're going to want to investigate that.
Thank you. Sorry to put you on the spot like that.
That's okay. Nancy was here for me.
Okay, well, a couple other things I'm wondering about. When we looked at the map, and we were a light pink, and then next is endorsed, a darker pink, and then mature is the darkest pink.
Right.
What's the differentiation between the three of them?
The developing is very broad. Developing is we're making an effort, and there's a lot of leeway in how far you are in that effort. Endorsed is when there's a list of certain requirements that you have to meet, and I don't have those in front of me, but they're available on POLST.org. But basically, it comes down to a document that is consistent with the paradigm documentation, a strict plan for oversight and governance of the POLST program, and an educational component, so that there is a formal program to educate people throughout the state. And that's really the piece that we lack the most in Minnesota. There has not been a strong educational component, and the hope is that this webinar will be the beginning of efforts to have an educational component in place to meet that requirement. Then as far as the difference between endorsed and mature, the biggest differentiation is time. How long have you been using your program, and how well covered is your entire state in using it consistently?
Great, thank you. Let's check one more time to see if there's any questions in the queue.
We have no questions at this time.
Okay.
Anybody else have comments or questions that they want to type in? Okay, don't forget what I said about the comment section on the survey, and I'll let Janelle close out this webinar.
All right. Well, thanks so much, Karen, for your presentation. This was great information. And it's nice to have the information about the new POLST as it's just hot off the press. The third and final webinar in this series will be on Thursday, September 14th, 1 to 2 p.m. Central Time, and the topic is Resolving Ethical Dilemmas in Advanced Care Planning. Karen will be presenting again for us, so thank you for that commitment for this whole year. In the evaluation, we do also ask if there are other topics that you're interested in, so as we think about planning the 2018 webinar series, we're interested to hear from you what you would like presentations on. So before you log out today, please complete the survey that will pop up. And once you've completed the evaluation, you will receive a certificate of completion. Please make sure that everyone on your team that participated in the webinar today receives a copy of that, and you can just make photocopies. The session was recorded and will be available on lsqin.org in about 2 weeks. Thanks, everybody, for participating, and have a great rest of your day.
Thank you, ladies and gentlemen. Thank you for participating. You may now disconnect.